Hi, everyone. Welcome. Thank you for attending Advances in the Technology of Tickborne Testing. I am Dr. Lily Lu Wing, and I will act as your moderator tonight. As moderator, I will respond to the live chat and Q&A throughout the presentation. And following the presentation, we will have about a couple minutes or 10 minutes or so for live Q&A. Attendees are in listening mode, so please submit your questions in the virtual Q&A or chat applications. This content of this webinar is for educational and informational purposes only. This information is not to be interpreted or mistaken for clinical advice. Please consult a medical professional or healthcare provider for medical advice, diagnosis, or treatment. And now let me introduce you to today's presenter, Dr. Kim Bruno, who is a clinical lab educator here at Vibrant America. Dr. Kim Bruno received her doctorate in chiropractic medicine from National University of Health Sciences in Chicago and successfully completed the Certified Clinical Nutritionist Board examination. She has continued her postgraduate education through the Institute for Functional Medicine, the Clinical Nutrition Certification Board, and Lyme Master courses. Dr. Bruno has dedicated her career to working to find the root cause of patients' medical issues, as well as promoting a prevention model of healthcare. Prior to coming to Vibrant America, she owned a private practice and worked hand in hand with a variety of healthcare providers in multidisciplinary practices. Most recently, she was the functional medicine director at the largest immunology clinic in Colorado and specialized in complex care of patients with multiple chronic immune conditions. Dr. Bruno is a Colorado native who enjoys hiking and paddleboarding. She finds most joy in spending time outside in nature with her husband and 2 daughters. With that said, let me give it over to you, Dr. Bruno.
Thank you so much, Dr. Lily, for that great introduction. And thank you so much, providers, for joining us and spending your evening with us today to talk about the advances in the technology of tick-borne testing. So before we get started into the technology, I just want to give you a little bit of a story of maybe why I am in the world, how I got into the world of tick-borne, because sometimes, this was not my path. I was not planning to be, someone who treated a lot of tick-borne illnesses. But in 2014, we had a lot of big life events within my family, and my husband ended up getting diagnosed. He was originally from Connecticut. He actually really pushed me to test him. And I kind of was like dragging my feet, saying like, no, it's not Lyme. Like, we live in Colorado. And he's like, yeah, but I grew up in Connecticut and I'm a mountain biker and these different things. And so I tested him, and lo and behold, he was positive. And it clinically correlated. We ended up having him see one of my colleagues. And as any of you know, like, once you have a family member who enters in this world of Lyme, whether you want to treat it or not, you kind of have to jump into the deep end of the pool. And so I learned alongside this colleague of mine through his treatment, through his relapses, and then it started, you would have one patient who was like, oh, you had a success story with your husband. And then lo and behold, here we are many years later, and I am educating you on tick-borne testing. So it's always interesting how people end up treating the things that they're treating or interpreting labs the way that they are. And I think that gives a little bit of a good background for me. So if you are one of those providers who's maybe not treating Lyme now, and you want to either learn or maybe just have a better idea about it, even if you're going to refer out, then this is a really great webinar for you. So today we have kind of a hefty list of things that we're going to get through. So I'm going to do my very best to keep us within time. But this is going to be the kind of evolution or the journey that we're going to take today. Is we're going to talk about who is Vibrant and the prevalence of Lyme. We're going to talk about why this should be added to your differential diagnosis list, even if it's something that you don't normally treat, key limitations of traditional testing methodology, and then the advantages of the Immunochip technology. So that's really going to be the bulk of our talk tonight. We will review our publications, certifications, and accreditations, what's on our panel. And then, of course, because we're clinicians, we want to look at a clinical case and the lab interpretation. I am not a medical lab scientist. I don't claim to be. I will present the technology to you so that you have a really good understanding of why Vibrant is different in the marketplace. But then we're going to see, how do we apply it to a clinical case. So who is Vibrant? A lot of you may be Vibrant providers already. If you are not, welcome. Vibrant really is a technology company in the lab space. And we have this very advanced technology that I'm going to explain today, which helps us increase our accuracy and our reproducibility of testing, but also allows us to have very comprehensive tests at an improved price point because of that technology and automation. A lot of the limitations of traditional tick-borne testing get eliminated when we use this new type of technology. Then we are always going to use our new methodology against and vet it against current gold standards. So when we do the lab interpretation, you're going to see information about like the CDC Lyme criteria, and that is also present in our publication because we want to make sure that we are putting out there with kind of what is the standard. We really value accreditation, third-party validations, publications, more so than flashy marketing. And we want to make sure that we always have really good data around the tests that we bring to market. In that sense, we have been published in Nature, which we'll review today. We also have had some published partnerships with Johns Hopkins, Mayo Clinic, and Cleveland Clinic, just to name a few. Vibrant is vertically integrated, which means we manufacture everything in-house. That should give you as the provider peace of mind because that means that we have full control over all of our reagents, our kit materials. We can perform quality control on every single batch so that we know what is going out is accurate. So Lyme disease is very prevalent in the United States. This map is a little bit misleading. This is from 2019 from the CDC. And the reason why it's misleading is because it was, it's showing really about 35,000 confirmed cases, but this is based on data that was submitted, voluntarily submitted, only based on that CDC criteria. The other thing is this was done and during kind of that 2020 range when they were collecting the data. And so they did say that there was some interference or drop in numbers due to that. So although we want to look at this and it is, compelling that there are definitely pockets that are more prevalent, we do want to note that there is Lyme and ticks in all 50 states. And it's much more widespread than this is being presented. Case in point, if we look at a different level of metrics where now we're utilizing self-reporting, insurance claims, linking billing codes to antimicrobial medications, now we're looking at almost 500,000 Americans that are diagnosed and treated for Lyme annually. So we're looking at a very large discrepancy between about 35,000 and 500,000. Most of that's due to that data collection. So we know that this is, regardless of the number, is a big burden on the healthcare system. And what we need, and why one of the big reasons that Vibrant entered into this marketplace, is we need more consistent and accurate testing that can become the accepted testing so that patients are not falling through the cracks. Now you may say, well, I don't really treat Lyme. Well, do you have patients who have fatigue or joint pain or muscle pain or memory issues or sleep problems? I'm pretty sure that these are patients that you have in your practice right now. And many of these patients, if they've not been worked up for this, and then you start going down the treatment pathway, maybe something more standard, and they're not getting better, it should be part of your differential diagnosis. We should bring it in because it is the great imitator. And we often want to make sure, again, patients are not falling through the cracks because so often we can have somebody who has Lyme disease, but instead we're being told it's chronic fatigue or something else of that nature. So we want to make sure that we're at least identifying them. Here's a great article, again, of like, I don't treat Lyme, so why should I test for it? Well, just because you test for it doesn't necessarily mean you need to be the treating doctor, but you can test for it and then you can refer them, but at least you are putting it out there, and so the patient is able to get the help that they need. This is specific for COVID-19 as far as patients who have had exposures to Borrelia species having an increased COVID-19 severity in their infection. So that is one great reason to be able to test for this and just know what we're looking at. It's going to complicate their proper immune system response. It's going to cause mitochondrial dysfunction, oxidative stress. So again, most of the patients who are walking into a functional medicine office, it is at least something that we should do some questioning on, look at their history, and then do what we talk about later is called pretest probability of figuring out, is this something that I should add to their differential diagnosis? So then you decide to test. Well, there's a reason why a lot of providers for a long time did not want to test for tick-borne, because the testing had a lot of limitations and shortcomings. And when you have a lot of areas of gray or shortcomings in testing with a condition that already presents in so many different ways, sometimes providers will step back and say, I just don't even want to jump into that pool. These are really, so what we're going to do is we're going to go over some of the clinical limitations, and then we're going to start talking about the diagnostics and those shortcomings, and then what Vibrant has to offer. So clinically, there can be a delayed onset of serology markers. High levels of IgGs can mask those IgMs. 50% or less patients develop the bullseye rash. 20% of patients will continue to have symptoms after antibiotic treatment. Tick-borne microbes tend to hide in biofilms. I think another thing that maybe providers are not aware of is that the tick that can bite a patient and transmit Lyme disease can be the nymph, and that's the size of a poppy seed. So it doesn't have to be this big engorged tick that you're finding and then you're finding a huge rash. And so a lot of times patients will say, yeah, I've never been bitten by a tick. That doesn't necessarily mean that we shouldn't look into, is it a possibility of a tick-borne illness? Because it could have been a nymph that didn't show in a rash, okay? As far as the technology goes, those diagnostics, the current shortcomings, we're going to talk about indirect testing and direct testing today. And then we're going to bring that all together in the case. So direct versus indirect test, which one is better? Which one should we use? Well, the direct testing is looking for the actual genetic material of the organisms. In the chronic patient, that genetic material is not always present because these are stealth organisms. They're in the tissues, they're in the joint space, they're in the brain, they're in the cardiovascular system. And so it's possible that it's not even there. The more gold standard of tick-borne testing is indirect testing, but that is looking at the immune system's response to the organism. And you're looking at the immune system's response in an immune system that could have been kind of hijacked by the organism itself. So that leads in a lot of shades of gray, which is why you want to have very, very sensitive and specific testing. So that really gives us two buckets. What we're going to do today is we're going to talk about the shortcomings of the indirect testing, the ELISA, Western blot, Immunoblot, and the traditional, and then the direct testing of the traditional PCR. And then we're going to switch gears and talk about how the new technology that Vibrant offers really overcomes those shortcomings to offer a better test. Okay, so here's your ELISA. So this plate, this would be what would be considered an ELISA plate. Each one of these wells has one protein in it. Usually it's something like a whole cell sonicate or VLSE1, but it's one protein for one patient. And you can only do one protein per this plate. So they may be able to do 96 different patients on this one plate, but again, only for one protein. When we start going over our analyte list of what we can offer, if we're offering 100 different analytes, you would be looking to do run ELISAs on all of those at 100 different plates. So right there, you already have a test that's expensive and it's laborious. it can never be really scaled to get a bigger antigen type or antigen set. And when you don't have as many antigens, the likelihood that you're going to miss something is really high. It also uses something called chromogenic detection, which has a low sensitivity. And so you're just not going to be able to pick up that level of emission of light that we would like to. So therefore, you're going to miss about 60% of acute cases. Now, these shortcomings have been well known for a long period of time, hence why the Western Blot came out. The Western Blot offers the ability to see multiple recumbent antigens in one section, so they're not having to do those individual plates. But what it does, and the limitations of the Western Blot, is it has a gel gradient, and the consistency of that gel can vary. And then you're separating out the antigens by molecular weight. Well, similar antigens have similar weights, and so you get a lot of cross-reactivity. And so therefore, you can have high quantities of false positives or false negatives or wrong positives. And this became so commonplace that a lot of providers who utilize Western Blot would see particular bands coming through on the Western Blot and like wouldn't even consider that it's Lyme because it's like so often cross-reactive with Epstein-Barr or something else. So this test really, it helped to increase that antigen set, but it didn't increase the sensitivity and specificity because of those because of that molecular weight and the cross-reactivity. So then we have the Immunoblot, which is a better technology as compared to the Western Blot. This uses a technique of spraying proteins onto a cellulose type matrix. But when you do that, when you use this type of spray, you still can have some homogeneity, some reproducibility issues. You're still relying on separation of weight, proteins by size and charge. So there's still going to be some of those issues there. You need to have a skilled technician to interpret these bands, and those can be interpreted differently among different technicians. Because of this technology, you still are not going to be able to have the automation that happens. And so prices tend to be really high. And that's one thing that I remember in 2014 coming into the tick-borne space. It's like how outrageous the pricing was just to get some accurate testing that we wanted to look at. So the testing is accurate, yes, but the pricing is really high. And we also don't have a very big antigen set that we can work from because they're, again, going to be limited by the technology. The direct testing from a traditional perspective, as we mentioned before, sensitivity for PCRs tends to be quite low. And in the chronic patient, having the idea of that genetic material in the sample is even lower. Lyme bacteria is also create biofilms, and then the PCR detection would not be, it would not happen at that point. And traditional PCR testing is looking at one genetic sequence. So the best way to think of this is like when we're testing COVID, they're looking just for that spike protein. So PCR testing tends to be a better choice in the acute patient, but you still want to use a multiplex PCR, which is what we'll talk about with Vibrance, so that you can look at multiple gene sequences. So that is going to be a problem with kind of your traditional PCR testing. All right, so now that we have a little bit of an idea of what are the limitations, and I like to lay it out because it's like, what are the limitations so that we know what we need to do to correct it. So we're going to talk about our protein microarray technology. Better testing for better outcomes. And that's ultimately what we want to do as providers, is to have better outcomes for our patients. So before we go on, I'm going to take a minute to discuss our certifications and accreditations, because having technology is one piece of the puzzle, but you want to be able to have proof of the accuracy and the high lab standards, or the high standards of the labs is held to make sure that as a clinician, we are getting the accuracy of the testing that we need. So first off, we have a CLIA certification. I want you to think about your CLIA certification in the lab space as like your driver's license, okay?
most people, you need a CLIA certification just to run your lab. So it's like, we have that, that's great. But where Vibrant goes above and beyond is that we have a CAP accreditation. So CAP accreditation is your College of American Pathologists. It's the most respected choice to achieve accreditation. It's the highest level of regulatory compliance. We received our CAP accreditation in 2015, and we have passed every test from them to always keep it. The testing means on-site inspections, blinded samples sent to us, unblinded samples sent to us. And so we have to pass this rigorous and ongoing testing to make sure that we are held to this very high standard and have the accuracy that we claim to have. So this is really a nice feature that Vibrant offers that other functional medicine labs in the space do not offer, to be able to have this additional accreditation. Okay, so back to the technology. Now, what we're going to talk about for the next several slides is the indirect testing, the Immunochip. Now, when I first started working for Vibrant, I had been using the test panel for a while, but I really needed to learn the technology when I started working with the lab directly. I'm a very visual person, so this picture actually came out of our publication, and it helped me to really wrap my head around what exactly are we doing here. So think about when I taught with the Western blot and it like separated out by weight, right? Well, what we do at Vibrant, we have this silicon wafer, and then we separate out those antigens. Those antigens are isolated and separated prior to then placing on an individual chip. The chips are then placed onto these tapes, and then the tapes are placed onto a pillar, and the pillar is placed onto a plate. To give you an idea, this entire plate, which has 24 pillars on it, is about the size of 2 decks of cards. And that means that we have 24 different patients' samples, because there's a different patient on each one of those pillars. And then there's 100 chips on each one of the pillars. So one plate that could be the size of 2 decks of cards is going to test 2,400 different analytes or 24 different patients in their panels. So that's what we're talking about as this technology is scalable, and then everything is done in automation because these plates are then just run through the computer machines. So what does this look like? It's one thing to kind of know how it's laid out there, but let's look. So this would be what the pillar would look like, and these are all your little chips right here. This pillar is about 2 millimeters by 2 millimeters, and this is what it would look like with the recumbent antigens that are run through a Western blot, and the proteins or the VLSE1, the peptides, something that might be run on an ELISA plate. So you can see that each one of those antigens becomes a chip, okay? And then you can think about maybe the co-infections as part of that panel are these little white chips, and maybe some of the opportunistic infections or some of the others. So that is why we can offer the level of testing that we can in something like a dried blood spot, because we are doing it on this little 2 millimeter by 2 millimeter pillar that has all these chips on it. We are testing the same antigens, right? The same bands. We're just doing it in a different type of technology, different type of methodology. So one of those advantages that is that we're going to be using all different types of antigen types. So it's not just a whole cell sonicate, it's not just a peptide. We're going to be able to test all of them because we have room on that chip, and we are room on that pillar with all the different chips. So therefore, we can offer more species. Sometimes that can be a little overwhelming, and when we get to the lab test, we can talk about that, but it's because maybe somebody is not positive for Borrelia burgdorferi, but they're positive for Borrelia mayoni. Well, we would want to know that, right? Rather than just testing them for burgdorferi, it's negative, and then we don't treat them appropriately. So if we're testing for those 17 different Borrelia strains because we can, then we don't miss things. So this is your advantages of your Immunochip technology. So we have no gel matrix effects. Remember, 1 protein per chip. The proteins are separated and purified before going onto the chip, which eliminates your cross-reactivity. We can utilize up to 100 chips per that 1 pillar. And therefore, as new literature comes and those new antigens can be validated, we can add them onto our panels. Then we have high reproducibility due to the automation. We're not dealing with any type of human error of how different bands are reading out. It is all completely automated. As I mentioned before, we are vertically integrated. So we do hold the ISO 13485 GMP manufacturing certificate. That's a medical device certificate, and that holds us to a high standard when we're talking about those silicon chips. So what actually happens on the chip? Why and how can we get an increased sensitivity now that we know what the chip looks like and what the technology is? It's really 2 steps or 2 pieces that help to give us that sensitivity in the indirect testing. So the first part of it is the chemiluminescence. So chemiluminescence is still an emission of light, similar to when we talked about with the ELISA, that chromogenetic detection. But the chemiluminescence is just much more sensitive, and it can detect at a much lower level of antibodies. So we utilize, once it's on the chip and we're looking for that antibody to antigen binding with emission of light, if we utilize a chemiluminescence, we can already detect at a much lower level of antibodies. And then we utilize something called an enhanced IgM. So often if a patient has a lot of IgGs, they can mask or cause it so that IgMs are not tested appropriately, right? It kind of just clouds the picture. So we come in and we test for all your IgGs, and then we can clear out your IgGs and test just the IgM binding. So we can improve the IgM binding by kind of unmuddying the water. So when we do that, we have what we call this kind of twin advantages, and those 2 things together help increase our sensitivity. So that is exactly what was written up in our third-party publication in the Journal of Nature. So your conclusion here, the chemiluminescence-based assay with the enhanced binding of IgM provides that twin advantage of better detection and accurate results. These advantages, coupled with a complete set of antigen tested for the vibrant chip, makes it the ideal test for detection of tick-borne infections. And again, that was published in the Journal of Nature in October of 2020. So if you really want to dive into the medical science, I encourage you to do that. And this is figure 3 from the publication that goes over the cohort, and it talks about, numbers based on standard 2-tier testing, then based in standard testing utilizing the Immunochip, and then utilizing the enhanced IgM on the Immunochip. And then down here, we have your established markers, which is the CDC. And then we have what's deemed the investigational markers, which ends up being the alternative Lyme criteria. So I know these numbers are really small. So this is just a breakdown here that we're increasing, utilizing the alternative-based criteria. We're increasing to 100% sensitivity with a 95% specificity, and we still maintain 95% reproducibility. We do have those 4 published validations. So that is what is going to be coming through as far as our sensitivity and specificity. Just as a recap, how I like to explain it to my patients, because when they're asking about, accuracy of testing, I like to explain that sensitivity and specificity like the needle in the haystack. The sensitivity is the likelihood that I'm going to find the needle, and the specificity is the percentage that I know that it's a needle and it's not something else like a pin or another fragment of metal. So if you have 100% sensitivity, you're 100% going to find the needle in the haystack, and 95% specificity that you know that it's actually 95% of the time you know that it's actually a needle. So you want to make sure that both of those numbers maintain are as high as possible. Now, I often get the question, what is the difference between the alternative criteria? Why do you have that to increase the sensitivity? That really goes back to the CDC criteria as having as not being as up to date as we would like it to be. You know, the CDC criteria was developed as a surveillance criteria back in the early 80s, hasn't seen a lot of updates since then. There is the alternative set is based on more current research of the bands that are utilized to get us to a positive. So as you will see, you know, when we're looking like at an IgG, we're looking at CDC is only accepting positives, and they have a much narrower level of bands that they accept. They want 5 bands out of, they don't include 31 and 34, which actually are highly specific bands for Lyme. And then the alternative Lyme criteria, we accept moderates or positives, and then we can do 2 of any of those 12 bands that would be in that on that Immunochip to bring through. So that helps us to get that increased level of sensitivity, make sure those patients aren't falling through the cracks. So that is everything about the indirect test. We do also offer direct testing, and it's part of our panels. So this is not something you have to pick and choose. I know that at other labs, it's like, oh, do I want to do the PCR? Do I want to do the immunology, the serology? I mean, as a provider, you ultimately want to do both, right? You want to gather as much information as possible. So we offer PCRs on every single one of our tests, and you don't have to order it separately. It's part of the panels. But what we also do so that we can help give you more information as a provider is we've increased the sensitivity by having multiple target genes. So we're not just looking for one, we've got multiple target genes. We've got some amplification so that we can increase that sensitivity. And then we also have something that's called bead-beating. So this is not something you have to order or request. It's done on every run, is that the sample is agitated by glass beads to break up any biofilm that may be there that could be harboring away and protecting the genetic material. And so therefore, if it's in the sample, we will pick it up. Okay, so you still deal with, you know, chronic patients. It's possible that genetic material is just not in the blood. But if it is there between the bead beating, the multiple target genes, and the amplification, we're going to be able to pick it up with a higher level of sensitivity. So what does that look like on our panel? So all of that multiplexing, whether it's for the indirect test, the direct test, it ultimately comes down that because of the chip technology, we're able to offer this most comprehensive panel on the market. And these are all the different species that we're looking at. Now, I like this next slide because it breaks it down a little bit differently, but it helps to really give you an idea of what you're looking at. So your full analyte offerings, well, let me go back here actually. So they're broken up into columns. So the first thing we're looking at is the indirect testing. Okay, so this is all your IgGs and IgMs. But as you can see under here, like we have Borrelia burgdorferi, but we have all these different recombinant antigens and peptides and whole cell sonicates. So that is where we are helping to increase the likelihood that we are going to pick this up. Same with Afzelii or Garini. So we have a high number of Borrelia strains, and we can separate them out in some situations, depending on what's available for those antigen sets. Same with co-infections. And if you order the Lyme plus tick-borne relapsing fever and co-infections 1, that is called the Tickborne 1.0. You get everything in these 2 columns. If you order all 4 columns, you get the first 2 with the co-infections 2 and opportunistic infections. That's called your Tickborne 2.0. And then you can also customize that. Let's say, you know, you did the 2.0 and then you were doing treatment and all you really wanted to test was the Lyme and then the co-infections 2 based on the treatment, based on the results they had the first time. You can order individual columns as well. Okay. So these are the PCRs that go along. I know there's a little overlapping here. This chart is in your provider portal so that you can see that complete analyte offering that we have for both the indirect and the direct testing. So what I like to say is with Vibrant, you can have your cake and eat it too, right? So you're going to get those maximum number of Borrelia species across the different antigen types. You're going to get your direct and your indirect testing, maximum number of co-infections, maintaining high levels of sensitivity and specificity, and in some situations, higher levels of sensitivity, maintaining the specificity, short turnaround times, easy collection. You can do this in a blood draw or a dried blood spot. And then competitive pricing. Because of the technology that we talked about tonight, that's what helps us have test panels that are more comprehensive and still a fraction of the price of our competitors. And what does that do for the Lyme patient? That lets them have more money for treatment, because you and I know, being clinicians, if you start testing for Lyme, you're going to find some patients who have it, and that's a long road of treatment. So you want to make sure that we don't use $3,000 in testing when we need to turn around and also do treatment. All right. So this is really about making sure that the patient can get the best treatment or the best testing, and then also that follow-up treatment that they need. Okay. So now the fun part. Remember, I told you I was not a medical lab scientist. I do love this technology because of what it brings to the tick-borne space. Having had a family member who has gone through this, I know that accurate testing is so important. And seeing how many patients' lives have changed because I've had accurate testing through Vibrant and been able to apply it clinically is really powerful. So what we're going to do today is, I'm going to call it a case study. It really is about the lab interpretation, but I'm also going to walk you through, like, what is my thought process when a patient is sitting in front of me and I'm thinking maybe I should order some tick-borne testing for them, and then some lab interpretation. Okay, so first things first, we all need to remember that tick-borne Lyme disease will ultimately be a clinical diagnosis, okay? But what you utilize your testing for is to give you the serological framework to make an educated clinical diagnosis, okay? We don't want to just pull things out of the air. We really want to make that educated clinical diagnosis. So I like to explain it. It's like giving me the framework of the house, and then everything else, my complete history. Maybe I'm doing an MSIDS questionnaire. Maybe I'm looking at, some other types of specific symptoms. That helps to build the rest of my house. Give me some drywall and put some roofing up and that type of thing to make my decision. So what you want to do when you're trying to make this clinical diagnosis is take a complete and detailed history. So we all do that as a provider. We're not going to stop doing that. We're going to take a very complete and detailed history. You may be already running some sort of questionnaire in your office, maybe like an MSQ. I will tell you that if you have a very high off the charts MSQ, something like over 100, this is maybe a road that you need to look down. So it's not, one for one, but it's something that we're like, there's something else going on there. There's also the MSIDS questionnaire put out by Dr. Richard Horowitz that is validated for that clinical presentation, clinical diagnostic tool of Lyme. So you do your pretest probability, and then you run into, okay, now I'm going to do my testing, and then you use your direct and indirect testing like we talked about. So this is our patient. She is 48. She lives in Minnesota. She likes to be outdoors. She has had several tick bites, but no EM rash, no acute Lyme disease. She's had some international travel. Again, no tick bites that she knows of on these trips. In the last 5 years, she's had some brain fog, trouble concentrating, some chronic headaches, consistently gaining weight. In the last 6 to 12 months, she's had increased stress, which also increased her fatigue and brain fog. And increasing her number of headaches, some cognitive decline, some word-finding issues, some joint pain. She has no endurance. She loves outside activities, but she finds it hard to recover. And if she does exercise, then she tends to have this kind of systemic inflammation for days. She's getting some night sweats. They're getting progressively worse. Her symptoms do tend to kind of wax and wane. although she just never really feels well. Unfortunately, this patient falls into the category of particularly women that I feel get labeled as kind of your dismissed disorders. She's gone to several providers. She's been told it's all in her head. Oh, but you look so healthy. You just need some sleep. Oh, well, you're just getting older. All your labs are normal. I mean, on and on and on, right? This woman has been told all these things and she just doesn't feel well. And she's been dismissed by several providers. Okay, so we did run MSQ, MSIDS. So she does have a fairly high MSQ. MSIDS is at 48, which puts her in high probability of tick-borne disease. And that leads us to saying, yes, we should do some tick-borne testing for her. She lives in an endemic area. She's had some tick bites. She's got a whole bunch of symptoms. Other labs are looking normal. She's got a high MSIDS, high MSQ. Like you can see where that pretest probability comes together. So when we get our summary page, the summary page is just that. It is a summary. It is not where you're going to get your nitty-gritty, where you make your clinical decisions from, but it's a great page to refer back to. So unlike something like maybe a food sensitivity test where maybe all you need is the summary page, I really want you to think of the tick-borne summary page as just your summary and something to come back to. But what I'm going to do is stop here just to kind of go over the reference ranges. So your IgG moderates, and in the rest of the test, when you see it, they'll be coded as yellow. They're between 10 and 20, 10.1 and 20. That's most likely indicative of a past exposure. Now, we can clinically correlate that. We can talk about immune system function. There's a lot of things we can talk about in that realm. But most of the time, those moderate IgGs are going to be indicative of a past exposure. Now, when we have a high IgG, this could be a past exposure, but it also could be a chronic marker. It also could be a reactivation. This is where we really dig deep into the clinical correlation based on how the patient is presenting. And then your IgMs, whether they're moderate or high, so either yellow or red, is indicative of an active immune system response, okay? May not be acute. We do have some evidence with Borrelia that we can have some IgMs, persistent IgMs 10 to 20 years after exposure, but we are continually, the immune system is sending in the Marines, right? So you've got the Marines going in, we have some sort of active immune system response. Every one of these serological markers does need to be clinically correlated to be able to make our final decision. Clinical decision. So what does that look like on the test? Well, this is what it looks like as far as our Borrelia burgdorferi. So Borrelia burgdorferi is that primary spirochete that's causative of Lyme here in North America. It's the one that has the criteria. And so when you look at the Borrelia burgdorferi page, it is almost like a standalone. These negatives and positives down here only relate to the burgdorferi. They're not for the entire test. They're really just talking about the burgdorferi. So we need to look at a combination of like tier 1 testing and tier 2 testing, which was originally established in this 2-tier process of testing, but we just do it all on one page. So that means you're going to have this chance where you can get maybe, lists negatives and then it lists positives. This has everything to do with what the criteria are, what they accept, and at what level, all right? Now, based in our publication and based off of what the CDC says, when you have a patient who's been sick for longer than 30 days, you most commonly are going to be reading off of this IgG. And then because of the level of sensitivity, the CDC criteria is only about 63 to 72% sensitive versus the alternative Lyme criteria is 100% sensitive. So if we break those two things down, this is the box that you are going to be reading from, okay? You may have some persistent IgMs over here, helps to give us some clinical activity or clinical idea what might be going on, but we do really want to be paying attention when we're looking at the criteria in the chronic patient, IgGs, and then alternative Lyme criteria, and then that brings us to our positives. Now, I could read off like the number soup of the 2-tier technology or the 2-tier testing here for you. But I am a much more visual person. So again, I'm going to bring you back to this flow chart so that you can again see the difference. You will see, you'll have a recording of this presentation so you can see these slides. There also is a much fancier algorithm of this in your portal. So it's very well designed. And then it also gives you, what are your most likely clinical decisions based on what you're seeing through this algorithm. So I highly recommend that you get that Tickborne algorithm sheet that is in your provider portal. I have it laminated, so I can show it to the patients and talk to them, because they're going to see these negatives and positives all on the same page. And then they're going to have some questions, and you want to be able to explain why one is there and the other one isn't. Okay. So then we start, we already know we have a positive alternative Lyme criteria, and it matches with her clinical picture. So when we look at all of the other Borrelia species, we are just adding to that evidence of exposure. Depending on our treatment, we may not do anything different with our treatment for Miyamoti versus Burgdorferi, but we do want to know how many different species are we looking at here. So for her, she's had past exposure to Fzelli, past exposure to Bavarianesis. That makes sense with her international travel. She also has had exposure and some active immune system response, so positive IgM serology to the Miyamoti. This could very well have to do with some of that waxing and waning type of presentation for her Borrelia. Okay. Then we come in and we look at our co-infections. She's had evidence of exposure for Babesia and also evidence of exposure to Bartonella. Now, both of these are moderate. One is higher levels of moderate. Remember, 20.1 is the cutoff, so 19.4, that kind of puts us right up there at the line. I would clinically correlate this, make sure, is this a past exposure? Is it clinically relevant? I would look through some symptom profiles and I would say, okay, what are we looking at? Now, these are just some basics as far as symptom profiles. There's very complete ones and various different Lyme books that you can look through. And sometimes what I'll do when I have a patient who has an IgG that's moderate and it's close, or even when it's high, I go back and look through these symptom lists and I re-look through their history and start to match things up. So for her, she did not have anything in her history that matched up with Bartonella. Okay, none of these other, she didn't have any photophobias, no tachycardia, no anxiety or central nervous system issues, no neuropsychiatric outbursts or rage. But when we looked at her Babesia list, she does have night sweats. She does have headaches. Remember, her headaches were getting worse. And headaches tend to be one of those differentiating symptoms to look at. So your Babesia headaches tend to be dull and all over, like her head is in a vice, versus Bartonella headaches tend to be very much sharp and like an ice pick, okay? Versus Lyme headaches start kind of cervicogenic, come across the nape of the neck or across the occiput here and maybe up around the back of the head. So you can start to really dig into their type of headaches. And so we had a couple things that popped out, but still not something that I'm completely convinced with, because someone, she was 48, night sweats could be from something else, so we're not completely sold yet on the Babesia, but we do know she's had evidence of exposure and she has a little bit of clinical correlation. So I'll tell you what we're going to end up doing with that. Before I go through the conclusion of the test, I do just want to say, utilizing a total immunoglobulins when you order your tick-borne panel is extremely valuable information, because it helps you to get the framework of your overall immune system function. Like, what is the pool of IgGs and IgMs that you are pulling from, okay? So if you have low total IgG because the patient is immune compromised, and then you have a whole bunch of yellow IgGs and a very symptomatic patient, that may be much more significant, right? So we have to do a little bit of that clinical mental gymnastics, but having the pool to pull from the total is really important. So what does this look like? This is where I would end up with my conclusions based just on the tick-borne panel, okay? She is positive for Lyme, the Borrelia burgdorferi species with the alternative Lyme criteria for the IgG. She correlates that clinically, and she also has high probability of the MSIDS, which is also a validated tool for diagnosis. In addition to that, she's positive IgM serology for Borrelia miyamotoi. So that is number one. That is where we're going to start treating. What do we do about the co-infections? Well, we've clinically correlated that there's definite a possibility of a chronic marker for those symptoms that we talked about. So I tend to put them on the back burner while I'm treating for Borrelia. If those symptoms or other symptoms in that list pop up, get worse, then I may start adding in some treatment for Babesia at that time. I'm going to monitor it. Another course of action that you could do is you could do some retesting in about 6 weeks, and you could monitor the antibody movement. So if you have movement that we're increasing, it may be more a determination of an active infection or something that is reactivated in her system. And then the Bartonella, we didn't have any evidence of an active infection after we clinically correlated, appears only to be a past exposure. We wouldn't do much about that. We're just going to kind of let it be. We may consider, keep that list of symptoms in our mind. And again, as we break up biofilms, as we go through treatment for Borrelia, we're going to think about, she has had exposure to that before. Let's just stay on our toes and see if we might need something of that. We might need to address that later. All right. Now, I'm going to stop there as far as our tick-borne panel. At the end of the month, we're going to bring you another great webinar that will go much deeper into the comprehensive evaluation of the Lyme patient between utilizing tick-borne testing as well as other types of testing and evaluations. It's going to be a really great interactive webinar, so I encourage you to check that out. It's going to be at the end of the month. And I thank you all for joining us this evening, spending your time to learn about lab technology, and we hope you have a wonderful evening.
All right. Thank you, Dr. Bruno, for such an informative, relevant, and meaningful presentation. We will start with some Q&A questions that came in. The first one is it better to test for tick-borne diseases using a blood draw or blood as a dried blood spot for the collection of it?
Yeah, that's a great question. So we offer in both. The testing is validated in both and accurate at the same level in both. Clinically, what I feel is a better option is to do the blood draw. I know not everybody loves a blood draw, but when you do the blood draw, you can add those total immunoglobulins that I was talking about. Because remember, you want to know that pool that you're pulling from, and you can't do the total immunoglobulins in the blood spot. So it gives you a lot of extra value, and it's a free add-on, but you have to do it in the blood draw. So that is my opinion, but they're going to be validated in both with the same level of accuracy.
All right. The other question, when should I retest for tick-borne diseases?
Another good question. So it really is going to depend on the patient. It's going to depend on the treatment protocol. You don't want to retest too soon. How I would run it in my clinic is I would look at something like maybe 6 to 8 to 10 months. And it had to be an and. We've reached some sort of plateau. They weren't having any Herx reactions, no new symptoms popped up. I wasn't concerned about another co-infection. Like we had really kind of reached a nice plateau. The patient was feeling better. We saw some resolution of some of their primary symptoms. And then I would retest. And then what you're looking for is this conversion, right? You're looking for this transition of decreasing your IgMs, you over into IgGs, and if you're working just off of IgGs, decreasing those by like 10 to 20%. You're not looking for an all green test because this patient has had presentation, their immune system has seen these organisms before. So you're always going to have some IgM or IgG activity, but you're wanting that seroconversion, and then the drop paired with the clearance of the clinical presentation.
Thank you for that. So we're actually running a little long time for extra questions, but for some other ways to learn about tick-borne, the best ways would be to schedule a consult with a member of the clinical education team, such as Dr. Bruno here, or you can ask your sales rep about doing a precision clinical resource event, aka a PCR. All right. So thank you to all the attendees for your engagement and your business. Vibrant America appreciates your support and the work that you're doing to advance the functional medicine, disease prevention, and wellness model. Immediately following the webinar, you will receive a 5-question survey. Please complete the survey so we may gain insight into how well we're meeting your needs or how we may improve the clinical education program, products, and services we offer to you. Thank you. Have a great night, everyone.
Thank you. Thanks for joining us.